So let's take a case. Now, this is obviously a chest X-ray of somebody who's extremely ill, and you can actually make out that the patient has a, let me just try to show this to you here. This is the tip of the endotracheal tube. You can make out the right lung and you can make out the left lung. You can see the cardiac leads on the surface, and you can make out all these areas are the whitish stuff. This is what is called ground glass changes. The black stuff up here is actually what is the ventilated lung. So this is a 56-year-old male with diabetes, high blood pressure, exposed to SARS virus, CoV-2, he's having the cough, fever, hypoxia to 70% saturation, and he's had only 4 days of symptoms. He's been intubated, as you can see, for respiratory distress, and he's on the ventilator. He's a father of 2 teenage children, and he worked as a car mechanic. He lives in Hyderabad, and he's a non-smoker. See, currently he's on 100% FiO2 with the assist control or VC mode and a volume control mode. He is paralyzed. He has been on high doses of sedation, and his plateau pressure is 31 centimeters of water. His ABG shows a pH of 7.27, PSO2 of 60 millimeters of mercury, PO2 of 49 millimeters of mercury, a bicarbonate of 20, and a saturation of 77% on the monitor. And his ejection fraction on echocardiogram is 60%. That's a lot of information. Now, it would be interesting if all of you already knew all this. Otherwise, you would not be here if you knew all this. But there are tons of concepts here which we'll be going over today. And at the end of the next hour, we will have some kind of a basic understanding of what's going on and how to handle a patient like this. So what is ARDS? And some of you may or may not know this, but if you remember your textbooks of pathology, say Robbins, for example, ARDS is Acute Respiratory Distress Syndrome. It is extremely important because people die from ARDS. Despite the advances in critical care, people with ARDS don't make it quite often. But there are many things you can do to make sure that they actually survive, and that involves doing safe mechanical ventilation. The image on the right shows you what's called diffuse alveolar damage. And diffuse alveolar damage, this is the alveolar section, and you can see the hyaline deposits here, which are actually completely encasing and within the alveolar space, and there is no space for oxygen to exchange. This is the blood vessel structures, and you can actually make out that there is no space for things to go around. Now, the definition of ARDS involves having an acute onset, which is less than 1 week post the insult. It also involves a PF ratio less than 300 with somebody who's on a PEEP of 5. Chest X-ray should show bilateral airspace disease, and DAD is diffuse alveolar damage or edema, not explained by a cardiogenic issue. Stepping back to the previous case that we saw, this is a young male. Symptoms are within 1 week. It's only 4 days. He's got a high amount of oxygen requirement. He is having a plateau, which is high. He also has a saturation that is low, and the heart ejection fraction is 60%, suggesting his heart is pumping okay. So this is an example of what ARDS by definition is, and we'll understand more as we go along. Again, some of these concepts may not make sense, but just as a jigsaw puzzle, once you learn the basic concepts today, you will continue to understand what we're talking about. So let's take a look at the pathophysiology. Now, keep this image in mind, but before we go to this image, I'm going to have you visualize a balloon. You have a balloon in front of you, you're blowing it open. Assume the balloon is the lung, and when you try to blow the balloon open, initially it's a little bit difficult. You have to put a little bit of force in, and you have to keep pushing in, and then the balloon slowly opens up. In the video that you'll be seeing in a bit, you'll actually go through this example, and in your mind, create this image of this balloon you're blowing open, and that's the lung. Imagine that's the alveolus, and the balloon has a little stem to it, which is where you hold the balloon. That is the airway. Now, when you're trying to push it open, initially there's a little bit of resistance till the balloon opens up a bit, and that is, you can call the airway resistance to keep the airway opened up to get the air inside. Then the balloon has to slowly expand, depending on the thickness of the balloon. So you had a balloon made of bubble gum, it's going to blow up very easy. Suppose you had a balloon made of iron or steel, it's going to be extremely difficult to blow it open. So this is where the concept of compliance comes in, and we'll talk about this in a bit. And compliance, the definition is change in volume to change in pressure. If by this time you're not confused, then you're really smart. I would be confused if somebody kept talking about all these things to me and it wouldn't make sense. But let me assure you, it will make sense shortly. So this is that picture of the alveolus of the balloon. And you can actually see on the left side of the image, the alveolus, and you see some abnormal fluid. The leftmost part is a normal clear alveolus where the word alveolus is written. There is just air. But as you get ARDS, you end up with fluid inside the alveolus. And just as you have inflammation anywhere, say you bump your hand, you're going to get a swelling because of inflammation. Same thing happens inside the lung, and you end up with fluid building in. You get a lot of inflammatory cells, and the cells become leaky, and fluid leaks out into the interstitium, and that can cause swelling and an difficulty in exchanging oxygen and carbon dioxide. As time goes on, and look at the right side, some of those parts become scarred, and that is called fibrotic scarring. And most people with, you have a cut, you have a scar in the hand, likewise lung scars up and becomes fibrosis. And when you have fibrosis, it's very difficult to continue to exchange the oxygen and carbon dioxide, and that is an issue which we need to be aware of. What are the causes of ARDS? You might know this, and it's pretty easy. It's anything that fills up the lungs. Now, the lungs can get filled with three things. It can be blood, water, or pus. Blood, it is, say, for example, somebody with a alveolar hemorrhage. Say you want pus, it is a pneumonia. And if it is water, it is congestive heart failure. But in this particular situation for ARDS, if the lung has pneumonia for any cause, it can be viral, bacterial, sepsis related. And you can also have a condition with trauma where the lung is contused, or you kind of bang against the lung inside the chest cavity and there's a bruise on the lung, and that can lead to ARDS. People who aspirate when they're eating and the food goes into the lungs, that can happen. You can have pancreatitis, major burns. People getting blood transfusions can get lung injury and ARDS. People who have trauma, say you have a long bone fracture like a femur fracture, you can end up with ARDS in that situation too. People with blood infections or sepsis can have this. Inhalation injuries, people having an inhalation of a chemical. You might have heard of the recent chemical inhalation that happened due to styrene in the Vizag area in Visakhapatnam. Likewise, you can get some inhalation injury from that. And people who have near drowning, where they're actually having a situation of water entering their lungs, can also have ARDS triggered. The mortality in ARDS is actually pretty high. So there's a concept called the PF ratio. So we have gone through several concepts. We'll review those again. But essentially, the PF ratio is a PaO2, which is the oxygen in the blood, and the F is the FiO2, which is a fraction of inspired oxygen. FiO2, fraction of inspired oxygen. So if the FiO2 is 0.5, it means you're giving 50%. If the FiO2 is 0.3, you're giving 30%. So if you multiply the oxygen level and then you say make a calculation called the PF ratio. Suppose somebody's blood oxygen is 100 and you're giving them oxygen at 100%, the FiO2 is 1. So that becomes 100 by 1 and the PF ratio is 100. Suppose somebody's PO2 is actually 200 and you're giving them oxygen at say 50%, which is 0.5. That's 200 divided by 0.5, that ends up being 400. In general, the higher the PF ratio, the better the lungs. The concept is the PaO2 is high and your FiO2 is low. You need less oxygen to be given to get a better oxygenation. So essentially the PF ratio, they've stratified it and shown that if the PF ratio is less than 100, your mortality hits about 40% or more. If it is between 101 and 200, the mortality is about almost 35% or so. And if it is between 201 and 300, it's about 25% mortality. So these are not small numbers; they're pretty big numbers. But it is clearly shown that if you can improve the PF ratio, you can actually improve ARDS mortality. And this is another important concept to remember.